today's video, we're going to return to walking after major lower extremity surgery. You're doing great, doing good, nice. What's up guys, it's Dan from Fitness Pain Free. I'm a physical therapist and a strength coach. We've helped to make thousands of incredible clinicians through our online courses, communities, and mentoring programs. In today's video, we're gonna make you 1% better. Okay, so here's the problem. You have a patient, non-weight bearing for 4 weeks. Let's say they had a meniscus repair, and then they're allowed to full weight bear now, and they start to walk, and it looks terrible, and it's painful, and it's really sore. How do you progress people back to walking well? Today's video, I'm gonna break it down. My favorite ways I like to get people back to walking after a major lower extremity injury. So the first thing to keep in mind is that the type of injury that your patient had is going to dictate the type of compensation they have after a surgery. So if someone had a hip surgery, let's say a hip labral repair or PAO or a hip replacement, oftentimes they don't like to extend the leg back, or when they weight bear one side leg, they'll do what's called an abduction lurch. So when I take a step, I will lurch to the side to try to offload my hip. So you may notice your patients look kind of like this when they're walking, right? The other thing you might notice is they tend not to like to extend the surgical hip. So when they take a stride, usually they take a short step with the opposite side leg and a little flex when they take steps. Looks kind of like this. So a few cues you can try for these individuals is that when they're on the surgical leg, they stay nice and tall, or you can give them a mirror for biofeedback as they take a step. So as they take a step, make sure that everything's lined up well. Take a step, make sure everything is lined up well, okay? The other cue you can use for folks who don't like to extend at the hip is going to stay tall when you're on the surgical leg. So when they take a stride and they come through, as opposed to hunching here, you want them to be upright. So they take a step, they're nice and tall when they're on their surgical leg, and then the walking tends to look a lot better. The other thing to keep in mind, and this goes for all of their injuries, not just at the hip, is if you have a missing amount of range of motion or too much pain or weakness, you're gonna see a compensation regardless of what type of cue you tend to use. So if you have someone that has no hip extension, you can end up cueing them until the cows come home. It's not going to improve that limitation. So what you need to do is work on their hip extension and then simultaneously work on gait training, give them the right cues, so over the course of time, they restore hip extension and they use it with their daily activities like walking.
Hey yo, I've got something for you. It is an evidence-based cheat sheet on meniscus pathology. And I get it, stay on top of literature for all the pathologies that are coming out. Very tough as a physical therapist. Well, I'm gonna try to simplify it for you. I've taken all the relevant information about the meniscus and jammed it all together into a cheat sheet. And my promise to you is I'm gonna catch you up to date on meniscus pathology in under 10 minutes. In the cheat sheet, we go over mechanisms of injury, prevalence, acute injuries versus chronic injuries, anatomy of the meniscus, examination, types of meniscus tears, surgery versus physical therapy, and some rehabilitation principles for you. So I'll leave a link in the show notes in the description below. This is 100% free. Go ahead and click on that link, download it, and get learning. Now back to your video.
If you had a patient that had knee surgery and they're trying to get back to walking, generally what you find is that either the knee doesn't like to extend fully or it doesn't like to bend. So it's just stiff in general. So if you watch someone who has a very stiff knee that doesn't like to extend, it looks like the knee doesn't extend when the heel makes contact with the ground. So you take a step and then they kind of shrink down a little bit, more so than they normally would be, just because that knee doesn't fully extend, right? So the cue we like to use for these folks is that before your heel strikes, try to straighten out your leg and lead with the heel. What we're trying to do is get that leg straight before the heel touches, so when we transition on the leg, it's nice and straight, right? The second compensation that you might see are folks that have a very stiff leg and they don't like to bend. So it looks a bit like they have a peg leg. When they take a step through here, the leg kind of comes around where they rock to the side simply because they can't bend this leg to draw it straight through normally. So one good cue for these folks is that when they stride with the opposite side leg, make sure the knee bends. So literally, when the patient is walking, have them take a step with the opposite leg, bend the knee. Take a step with the outside leg, bend the knee. So I tell them to bend the knee when they're supposed to bend the knee, and over the course of time, they learn what normal is supposed to be like. And lastly, if you have patients that had foot or ankle surgeries, so think about your patients that had, let's say, ATFL reconstruction or ORIF surgery, the ankle tends to be very stiff. And because of this, these patients tend to walk with a little bit of toe out, right? And for these folks, I think you have to really try your best to restore the ankle dorsiflexion range of motion. And then when they're walking, it's a nice bit of feedback to have them walk in front of a mirror. Just make sure your toes are more or less symmetrical side to side. So some slight toe out is okay, as long as it's matching the opposite side leg, right? Another common thing you see with patients after they've just had surgery and they're allowed to walk is that their cadence with stepping is a little bit off. So you take a fast step, followed by a slow step, followed by a fast step, followed by a slow step. So it's a bit like this. They do step, 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 step. And what we're trying to do is get that rate to normalize. And the way I like to do that is through a metronome. So essentially I set a metronome, set it a little bit lower at first, just so people don't have to walk really, really fast. Turn it on, and you can hear it tick, 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 tick. And basically, I want you to walk to this metronome. So when you hear that tick, that's when your heel hits. Go ahead and try it. Good, and have it come on back. Good, and the same thing again. Tick, 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 tick. Take a breather. So obviously, we're filming this, so we're walking, in a 10-foot radius just so you can actually see what's going on. But in real life, we'd obviously have people have a lot of space so that over the course of time, they can practice walking a little bit further and it's a little more natural. And if you like your patients walking normally, you should also like this video. Another thing you see commonly, folks after they've had surgery getting back to walking, is that their step length is going to be varied. So essentially they take a short stride with one leg and a longer stride with another. So what I find is if I just bring a little bit of awareness to the patient so they understand that they're trying to have a normal step length and be symmetrical between sides, normally they can clean this up really well. But in cases where they're not able to clean this up well, I'll use some visual feedback with something like a ladder. So essentially, if I'm walking through a ladder, I'm going to have the same step length left to right. So using a ladder, it's going to be a very short stride. If this is going to be too short, you can practice putting cones. Just make sure they're equally set up between one another. So you're taking a step, 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 step. So every single step is going to be the exact same length so that patients over the course of time learn what normal is. A drill I like to use for my patients who have a very stiff knee are going to be cone stepovers. The reason why this is nice is because it makes us focus on bending the knee and then straightening the knee. Two things we just said that folks that have post-op knee surgery have trouble with. So essentially, have them set up, and when they take a step, they come up, they have to bend the knee, and then when they're landing, you want to have them land with their heel, the leg straight, transfer your weight over top of this leg with the leg straight, and we go the opposite side leg, same thing, knees bent, heels down, we take another step, knee up, knees bent, heel touches, leg straight, stay tall as you transfer weight over top. Another thing that happens with these patients as they transition back is that they tend to hold their arms like a robot while they're walking. So you're telling them to focus so much on what they're doing for their lower extremities that when they're walking, they kind of do something like this, right? So one of my favorite cues is just to relax the arms to walk normally. So if we just practice a whole bunch of metronome and they just learn to do this while they walk, my cue is relax those arms, let them swing normally, and usually it cleans up really well without any additional cueing. Another drill that I find particularly useful, especially for folks who are really fresh into weight bearing and they're having pain, they're having stiffness, soreness, or they're very fearful, is just a rocking drill in a split position. So essentially, we're split, and if the patient needs it, they can hold on to a table. They can also have a crutch in one side hand, cane, PVC pipe, whatever they need. And then from here, I'm trying to normalize some of those walking mechanics. Let's say that we had the lead side knee operated on. The patient's having a hard time straightening that leg out. So one of the things we can do is keep the weight on the non-surgical side, straighten this leg out, get that heel down, and then progress our weight over top of this leg slowly, and then just rock back to the start, right? Let's say your patient has more trouble with bending the backside knee, right? So imagine now my right side leg had the surgery. As I come forward, I'll just encourage them to bend the knee as they rock through, and then come straight back to the starting position. So you can work on either the front leg, straightening, or you can work on the backside leg, bending, right? We can do the same exact thing if someone's having a problem with that abduction lurch. So pretend like I now have my support to the side, and I had surgery on this side leg. These patients tend to do this. What we can do is just put a mirror in front of them and cue them to stay upright, so when they shift over onto that side where they had surgery, they can focus on staying upright. This is a lot safer and less scary than just walking on your own. And if you have a patient that has stiffness of the hip, when the leg is behind them, we can split this leg backwards, and as we transition our weight from the front leg to the back leg, we just make sure that we're not lurching forward this way or leaning forward this way while we're doing this drill. So the split stance rocking drill is a nice way to make it a lot easier and safer for those very irritable or painful patients that are especially fearful. And just to reiterate, if you have a patient that's lacking knee extension, if you're cueing them to straighten out their leg, lead with the heel, that's not going to fix the problem until you end up getting that full knee extension back. So do keep in mind that you have to simultaneously work on any deficits that the patient may have. Okay, so a lot of patients, they don't learn how to walk normally over the course of one visit. And the problem is, if you go from absolutely non-weight bearing to walking around in Costco the next day when you're allowed to walk, this knee might blow up and become super painful. So you have to transition slowly. What do I tend to do? I tend to tell patients how to do a few of these drills within the clinic and have them practice a little bit of walking. And then my instructions are that when you go home, let's say 2 to 3 times during the day, I want you to practice these drills again for about 5 minutes or so. Do that for 1 or 2 days, and then after 2 days of getting used to walking well, start doing a little walking around the home without the crutches. That's going really well for a couple days after that. Then we start doing some community walking. We're making it easy. So basically going to the convenience store or something along those lines. Again, don't go to Costco. And after that, we start doing more and more walking in the community. And if we really want to measure the amount of steps a patient is taking, we can have them hold a pedometer, and we can either use the phone, which has a pedometer app, or we can put one in their pocket or around their wrist. Essentially, we can measure how many steps they're taking throughout the course of the day. And I think this really helps to bring a little bit of awareness of how much walking a patient is doing. And if the patient comes in, their knee is super swollen, we looked at the amount of steps they took 8,000, they're used to taking 4,000, you can say, hey, you took way too many steps, let's dial it back. Try to keep it under 6,000 or so, right? But again, this is just a suggestion, not our patients are going to need this. All right, so now you're an expert with gait training with your patients, but you still might not know how to do the rest of the treatments you need. Well, I have a video to help you. I'll leave a link in the corner and go over all the treatments you're going to need to rehab your patients with something like post-op meniscus repair, where there is a long non-weight bearing period for a lot of patients. Click on that link, I'll see you in that video.